Great. Awesome. Well, thank you everyone for joining us today for our discussion about organized healthcare delivery systems. For those of you that don't know me, I am Lynn Kyleman-Cruz. I'm the Deputy Director for Senior and Disability Services. And on the phone with me today is also Director Newman, Policy Unit Manager Jordan Grant, and several others from our SDS training team that are helping and assisting with managing the chat and questions and answers so we get the most feedback as possible during our time together today. Also listening in and in the meeting today, or expected in the meeting today, is our lead federal contractor, Mary Sowers. Some of you may know Mary from her work and role as the Executive Director of the National Association for Directors of Developmental Disabilities Services, or NASDs, as we often call it using our acronyms. Mary is not here in that capacity, however, because we are fortunate enough to have her funded through our Centers for Medicare and Medicaid as our home and community-based services technical assistance contractor. And she's the lead on that contract. So we have been working together to ensure our suggested changes are in alignment with our other state and federal partners. And so we really appreciate her help, and thank you for joining us, Mary. And now I'm going to turn it over to Tony for some welcoming comments.
Thank you, Lynn. And I just wanted to thank everybody for joining. We've been doing a number of webinars this fall because we've heard from you that the more we can engage with you prior to the formal regulations development process, the better. So whether you're an individual who receives services from SDS, a family member, a care coordinator, provider agency, representative, or other stakeholder, I just wanted to say thank you for joining us. And thank you for engaging with us. We're looking forward to your questions and comments today and later if need be. I also, if she's on, I wanted to welcome and thank Mary Sowers, who Lynn just introduced, our technical assistant on this topic. One of the joys of my job is being able to connect with brilliant people around the country who have a perspective on senior and disability services in other states. Who can really help us zero in on what we need to do. Mary's one of those people who is helpful, solution-oriented, available to us when we need it, responsive, and she's helping us not just on this topic, but on other things that SDS is doing to try and improve our service delivery. So thank you, Mary. And finally, I want to thank all the members of the SDS team that have been working on this topic for years. This includes the entire group of SDS managers, some of whom have moved on into retirement or other positions since we started taking up this topic. Chief among these is Lynn Kyleman-Cruz, though. I joked the other day that Lynn's middle name, her deputy director title is the informal title here at SDS. In the state system, she's known as a division operations manager. And if you know Lynn, you know operations could be her middle name because she knows every corner of SDS's business and how they work together independently, how they affect you in the field, how they affect us, how they affect our sister divisions. We're really fortunate that since we took up this topic and have been working on it for years, Lynn has been a steady presence with us. So Lynn, with that, I'll turn it back to you.
Oh, thank you, Tony. That was very kind and appreciated. So moving to our next slide. This is our mission statement for Senior and Disability Services. And we like to start our webinars with our mission statement. And I think it's really important to remind stakeholders, partners, and ourselves about what we strive to achieve every day that we come to work or who we serve. So perhaps we don't always agree on the method to achieving our mission, but understanding what our purpose is may help us to identify common ground and allow each of us to keep an open mind through our discussions today. We'll provide opportunities to share with each other. And our only ask is that we always keep this mission in mind and that we do our best to keep our dialogue respectful and solution driven. One other thing to point out right away is that we are accepting feedback now, just as Tony mentioned, but we have not written regulations for this project yet. There will be additional opportunities to respond in writing after we have proposed regulations. So I hope to save plenty of time at the end for us to have ongoing dialogue and feedback about these things. The photos you see here are individuals that agreed to share their images with us. And some of the other photos I've used in the presentation are just from one of my recent trips. So they're just to keep you interested. They have nothing to do with the topics. So just a side note. And now Jordan Grant, our policy unit manager, is going to walk us through just some housekeeping items before we move to the content.
Hello, hi, my name is Jordan. I do want to just go over a couple of housekeeping things. I know many of us on the call today are familiar with Zoom and have used Zoom before, but just a reminder that during the presentation, we are going to have most microphones muted, and we will have opportunity at the end for your mics to be unmuted or for you to participate in the chat. And so just know that that is coming. When we do get to that point, you might see on the bottom of your Zoom screen, there's a button called reactions. So you can actually raise your hand. I'm going to raise mine now so you can see what that looks like. And then you can lower your hand and we will know and have team members standing by that can help unmute your microphone. The other big thing we want to make sure you know is that this webinar is being recorded. So please, please, please use discretion. Do not put PHI or names or protected health information of any kind in the chat or say it. If you do have specific questions, you can always email us, hssdsds.policy@alaska.gov. We're always happy to take emails and we can help with more specific situations in that venue. But for this one, we would like to keep things general, respectful, solution-oriented, and leave out any PHI or names or anything like that. And I think that's all we have for housekeeping today. Thanks, Lynn.
Awesome. Thank you, Jordan. So what do we want to get accomplished today? We would like to explain the history of why we need to make some of the changes so that everyone can understand it. We will describe what is an organized healthcare delivery system, and also acknowledge that we're describing today what the OHCDS, the organized healthcare delivery system, will be, but we acknowledge that we have a lot of work ahead of us to better define group home hab and family home habilitation. So, and of course, the real goal for today is to get your valuable feedback on the changes that we propose to make. Again, why are we here today? So what sort of led us down this path? So back in around 2016, the federal government implemented a rule called the settings rule, and we had to go in and determine which settings these rules applied to and how we go into the settings to adjust our practices. And through that work, it led us to the discovery of what we call a factoring issue, and I'll explain that more a little bit later. And it basically means that the payment wasn't being made in alignment with, or our payment structure is not set up in alignment with the Code of Federal Regulations. And we also discovered that our service definitions were lacking in clarity, which sort of led to some of the issues that we had. SDS pays for 24/7 residential habilitation support in our waivers through two primary mechanisms, and those are the family hab habilitation and the group home habilitation. We know that part of the issue came from the fact that homes providing family and group home habilitation were acting as subcontractors of the SDS certified and enrolled providers. And they were not set up in a way that was compliant with the rules. It's no fault of any of our providers. It was just the way that we had structured it. So these homes that we will refer to as renderers, because they deliver or render the service, they were not receiving the entire amount of the rate established for the service, because the certified provider was carving out an administrative fee, which we knew was happening, to be able to provide some level of oversight and to bill for the service. We know that because of this work that we did, we will have to adjust that. So in regulations, group home service was never really intended to be subcontracted. We never cared for it in regulations. What we did was we set up family home habilitation to operate under like a OHCDS, but we really didn't care for it in the right way in our waivers. And that was what the problem that we encountered. So we moved to correct it immediately and requiring group homes to be operated by certified and enrolled entities without subcontracting. And since the family home habilitation regulations were in place, we felt better about leaving those as they were until we could correct. And that's when we entered into contract with our federal partners to say, hey, hello, we have a problem with the way our payment structure is set up, and we need to fix it. And so that's where we sort of moved along to today. This is a sort of a timeline of where we were. So we identified the problem in 2016. And I think one of the biggest questions I've heard from stakeholder groups is, why has it taken you so long to do this when you started to correct it in 2017? So this slide isn't inclusive of everything we've done at the division, but it gives you sort of an overview of the time frame that we've been under. And these are just a few examples of the work we've done and why it's been hard to complete the goal of really completely finishing this project. And of course, this isn't meant to make excuses. I'm just trying to outline the facts. So if you see above on the blue line are all the things that happened, and you'll see sort of where we began work, we paused work, we began work, we paused work, until we are today at, again, the begin work phase. So the things I think are important for everyone to know is that, you know, our normal day-to-day work is affected by some of the bigger issues. And sometimes it takes us all hands on deck to get through some of those. So for an example, you know, we had an earthquake in 2018, and we were affected all the same as everyone else in Anchorage. Some people had major house damage to their homes. Same thing, we got to COVID, and we lost some of our own team members to COVID. Just as many of you did with family members. And so all through that, we also had to apply for our disaster relief and keep things operational and running through all of these types of things, in addition to our normal work or the projects that were already underway. The cyber attack in 2021, that affected really all of our division and department partners. And affected everyone on the phone today. So it's taken us a bit to regroup, come back to this project and really work through. I think it's also really important to point out that we felt like we needed to be very thorough in our research and engage with our federal partners, stakeholders, contractors to ensure we're going to develop a plan that has limited or no impact to beneficiaries. It all takes time, but we hope to keep moving with momentum. And since we've engaged with our HCBS technical assistance with Mary, we're very hopeful and thankful that we'll be able to keep this moving forward in the right direction. So when we reached out in 2021, we conducted a series of 3 stakeholder sessions on this topic, and to hear from all of you about your thoughts on our first ideas that we came up with. And regarding a lot about the definition of service and whether we should adopt an OHCDS model. Probably not everyone on the call was in those meetings, but I think we sort of put our heads together and put down on paper what we think we heard some of the major points were. So there was, I think, quite a bit of confusion about the difference between group home and family home rehabilitation as distinct services. And for the sake of this work today, I'm not going to go into a ton of detail about those distinctions. I think that is going to have to be in a future webinar, because we really want to focus on what an OHCDS is and how to move forward with that. We also heard from folks in those stakeholder meetings that individuals or families that wanted to be providers found the licensing regulations requirements overly burdensome. And so we're trying to figure out, could we simplify those? Some providers perceive that the insurance mandates were overly burdensome. So we'll have some questions for you today about that, and also have to give that a lot of thought and careful attention. And then we also heard from the folks that were acting as in the certified and enrolled capacity about a little bit of the risk that they were facing if a subcontractor failed to deliver quality services. And we wanted to address that and see how we could fix that and make people feel more comfortable with this work. So as we presented the differences and the options, we heard from people that the OHCDS seemed like the best path forward. And so that's what we really want to talk about today and focus our attention on. So again, we do understand we need to split and deal with group home family hab and identify those services as very separate. And I think that work is going to take some time for us. And we also have some newer specialized group home, specialized family hab services that we also have to develop sort of service definitions of and regulations to formalize those going forward. So we heard from a lot of people in the last webinar, and since then I've heard from people that you don't want us to touch the group home definitions, but we really, not right now, just deal with the family hab and get it over with. But we can't really do that because behind the scenes, our residential habilitation services, all of those are together in the same package. And for time efficiency, we're going to open that package one time. So we will be coming back to you, as I said before, with another webinar that talks about these services, and we will get your feedback on that before we write regulations or go out for regs. So what was the problem that we encountered? It's something called factoring, is the rule that we were up against for why we needed to correct this issue. And so to put it sort of, tried to figure out how to make this very, digestible, because it is hard to understand sometimes for folks. But Medicaid requires that the payment for services rendered go to the supplier of the service. And the supplier of the service is really the person that's giving the service. So the home, the family habilitation home. And it basically says that they will not reassign the claim to another person. Medicaid won't reassign the claim to another person or another direct arrangement, except under certain conditions. So Alaska did not require the supplier, the individual renderer, to be certified and enrolled in Medicaid, which is a requirement for receiving payment from Medicaid. And I don't know why these came up in odd order. I apologize for that. States are obligated under the Social Security Act to ensure that no payment under the plan for any care or service provided to an individual shall be made to anybody else, individual or the person or another entity providing such care or service. So we knew we needed to correct that going forward. So currently, the way we have it set up for family habilitation is Alaska pays the certified and enrolled entity because they are the only payable entity in our system, in our current structure. We can't pay a provider that isn't certified and enrolled. And so the way we have it set up, they extract the administrative fee from the claim, and then they pass through the remaining portion to the provider of the family home service. And that in and of itself is considered factoring. That's why we need to correct this going forward. So the method to correct it is basically there is an exception, and if we set up a contractual arrangement between the family home provider, who is the supplier of the service, and the certified and enrolled entity, and there's a contractual arrangement through an approved method. That's key, because there was always a contractual arrangement, but it wasn't through an approved method via per CMS. And so that's where we have to develop an organized healthcare delivery system. And the OHCDS allows the state to facilitate that voluntary direct payment reassignment, so long as the rendering provider then gets 100% of the services. So you avoid factoring that way, and we'll talk about how we'll set that up to make sure that that happens. So what is an organized healthcare delivery system? This is where it is an administrative agency that has specific administrative responsibilities. And the state, pretty much comes up with the idea or the design for what those administrative responsibilities will be, which we'll cover in another slide. So SDS plans to establish that OHCDS that would be responsible for ensuring each rendering family hab provider and adult host home, note that little part there, are overseen, they comply with all the Medicaid certification requirements. The OHCDS would be responsible for service administration, and they get paid an administrative fee separate from the payment to their home, to the renderer. This is not a mandatory thing, so providers who choose to use the OHCDS would not need to be certified directly by SDS. But each site would need to be enrolled in the Medicaid system and submit an attestation form that they agree to reassign their claims to the other provider. So there are two things that are new that we're proposing that are new in this slide. Well, three things. One is the OHCDS. The other is the host home, adult host home. So under Senate Bill 57, we were directed by the legislature to create an adult host home. I'll talk a little bit more about that, but those are things I want to point out in this particular slide. And also that individual providers would need to be enrolled in Medicaid. So it's not the same as enrollment for a large agency. We think we may have a pathway to make that much simpler, sort of like the personal care assistants or naming another site location for each provider. But enrolling each rendering provider is a change, obviously, from how we've done it in the past. And the state really believes it's important to enroll each site because this is the only method to show where a person in our services truly receives the service. So an example of that is if, let's say, Tony's Care is certified and enrolled provider of ResHab currently, he may operate and contract with, say, 15 other providers, 15 homes. But when Tony submits his claims for the, say, 30 people that live in those 15 homes, his address shows up all as 550 West Fifth Avenue because that's where he's certified and enrolled as a provider. So this means we have to check other certification forms, which are not always updated on time, and or other means to identify where those 30 people truly live. And this is a problem. We believe it is really important that we're always able to link a recipient to the location of the service delivery. And that is really important because that's what our partners, our federal partners, expect from us. So that's where we want to make this change, and hopefully we'll develop a way that will make it fairly easy to do. So how would an OHCDS change the flow of payments? One of the things that I think is really important to note, and I really want to emphasize this, so I've made this bright orange. Certified and enrolled provider keeps detailed notes of service delivery. That will not change with any system that we implement. I've had people ask, can we just get rid of service notes? To get paid Medicaid dollars, we could never get rid of service notes. It's one of the key factors of submitting a claim. And one of the things, if there are no notes or documentations of a service, by CMS standards, a claim would not be considered clean and should never be paid. So in the past, I've actually had these certified and enrolled providers call me as quality assurance and ask me to help mediate because homes didn't understand that they have to keep notes. And the certified entity was responsible for those notes. So I want to just make it clear that that is going to happen no matter how we set up a system. The home will always have to take notes of service delivery. The next part, and I've made these fairly simple, simplified, not simple, simplified. So the certified and enrolled provider verifies the service after they review the service documentations. They submit the claim for each service to the MMIS. And then how it's really set up is they receive the payment directly from the MMIS to their address, that 550 West 5th Avenue, Tony's Care. He gets the check or the deposit at that site. The flow of payments through the OHCDS is a little bit different. Though the payments, again, rendering provider always has to keep the detailed notes of the service delivery. Not going to change. Then the rendering provider voluntarily reassigns their claims to the OHCDS. So this means that the rendering provider, this doesn't happen at every service, at every claim that's submitted. I just wanted to highlight that that is one of the requirements, that we have a form that that shows that both people in the agreement understand the relationship and the relationship to Medicaid. And so that's one of the things that we will be requiring. And the provider would keep that on, the OHCDS would keep that on file. Probably the provider, the home, the rendering provider would keep that on file so that everybody is understanding of the agreement. And then these last bullets just show sort of the rendering provider would submit the documentation for each service to the OHCDS. The OHCDS would verify and submit the service claim to the MMIS. And then the OHCDS would submit the administrative fee claim to the MMIS, which would be different from the rendered service of family home habilitation. And then the OHCDS receives that payment back and is able to issue the entire payment to the rendering provider, and then they would keep their administrative fee. And that's different from how we currently have it structured. So how could an OHCDS help the family habilitation home rendering provider? They would act as the administration agency for those types, the adult host home and the family habilitation home. Again, they'd be paid separately. They may act as the biller for those homes that don't want to be certified directly in Medicaid. It's also really important. Every home has the option to come through the direct path to become an enrolled provider. So that means certification and enrollment into the Medicaid system. So we would never say no to that. You can always become certified and enrolled independently. You do not have to operate through an OHCDS. And they would provide an additional option for providers and hopefully allow more homes throughout Alaska. So what we hear from people is, the certification requirements are, too strict or too big. And, a smaller provider maybe doesn't have the staff or the business acuity to put it all together and submit the package. And that's what the OHCDS would assist with, to make it so that the person or the individual rendering provider meets the certification requirements, but doesn't have to submit the packet all on their own. And it really allows a business collaboration between the OHCDS and the rendering providers. And I know we felt like we had that before. It just wasn't, the payment structure was not set up correctly. So it allows those relationships to get back on track, or, you know, develop new relationships. And it allows some of those smaller homes, obviously, to set the example set by the OHCDS, and eases their sort of administrative burden. And we always want to be careful to consider that the OHCDS is the administrative entity. We want to keep them separate, so that there's very clear delineation about who's responsible for what things. And that's what we hope to talk a little bit about today. So Jordan put together this fun visual to show the different types of services that might use an OHCDS. Again, you'll notice we've added adult host home here, and we've added the specialized family hab adult, and specialized family hab child, and specialized group home, all on that individually certified and enrolled avenue. Because of the requirements to become a specialized requires 10 years of experience or accreditation and a few other things, it didn't feel appropriate to go through the OHCDS route, because those providers are going to really be intensive operating those homes. And so we felt like it needed to be individually certified and enrolled through an agency or a provider that has experience in those types of services. And then the OHCDS lane is where we're going to allow family hab child, adult host home, family hab adult could all come through that lane. So one of the things we do have to do for the adult host home is add a license type. So there are two licensing entities. There's the Office of Children's Services, which oversees community care licenses, and then there's residential licensing at Healthcare Services that oversees assisted living home licenses. So adult host home under SB 757 is a requirement that adds an additional license type that will be determined by residential licensing, but they'll have different requirements than the typical ALH license, making it hopefully, again, easier to become an adult host home with less oversight or less administrative burden. Senate Bill 57 authorized the system of homes, as I've said before, but it also requires not just the license type to be done, but also we will have to add a service definition or a service of adult host home. And for Medicaid to pay for that, we have to be, again, very clear about what that service description would look like and how we would frame that up going forward. And so we have had several webinars on adult host home. And I think that's really important, you know, when we talk about like service definitions, that we're able to get some more feedback about what should be in that home and what shouldn't be. I'm not sure that we've received a ton of feedback, but we're always open to it. So send away. So adding an OHCDS credential type is also another thing we have to set up. So that OHCDS certification type is saying that this administrative service organization meets this credential and has the experience, can demonstrate certain things, which we'll go over in the next slide, but to be able to oversee these other homes. So the family home habilitation, I simplified it again. This is not all inclusive of all requirements, but you know, the basic things are they have to be licensed, they have to be enrolled in MMIS. As I said, that's a new feature. And they have to meet the standards for certification for family home habilitation. But they do that through the organized healthcare delivery system who assists them with that. Then the adult host home is the same thing, just they have to be licensed as an adult host home and then enrolled in MMIS and meet the standards for adult host home. So what should be the certification requirements of the OHCDS? We could really use the help of providers that have had a contractual relationship under the current structure, either the entity, the certified enrolled entity, or the supplier, the rendering provider. Love to hear your feedback on this, because we have, at SCS, our idea for quality assurance or for program integrity, but, we don't always know the realities of how those organizations have operated, or the difficult aspects of it, the easier aspects of it. So we really need to hear from you. We would also like to see the entities that have some experience or can demonstrate their ability to function themselves and also help others thrive. And that's where we went sort of with, in our minds, a 3-year minimum experience as a provider of group home or family home habilitation. Because you've run a home, you've operated a place, you understand what it takes to get certified, licensed, how to operate, how to keep people safe, how to meet the quality assurance standards. Those are all things that we're looking for in that experience level for that credential. We also want to make sure that we don't have providers that have pending or active sanctions against them able to be certified to oversee other people. We want to make sure that we're taking the A team to help create more A team kind of thing. So that's another idea we had. The other thing is that when you're dealing with money and you're dealing with payment structure for other homes, let's just say an example that Tony's Care decided he wants to have, he wants to be an OHCDS, and he has not been able to demonstrate fiscal readiness or fiscal responsibility with his homes that he has now. That would be a difficult sell for us. So what we're looking for are people that are able to demonstrate their fiscal readiness and to show that they can handle payments to other people, because we all know that's really what providers need to have happen: a payment structure and a payment that allows people to thrive. And of course, ideally, just as in all business relationships, we want to see an OHCDS be professional, great communicators, organized, fiscally savvy, so much more, anything. But we really need to hear from you. So if you want to let us know, what else could we do? Are we being reasonable? Are we being too lenient? What are your thoughts on that? We'd love to hear from you. I don't know how many times I'm going to say that in this presentation, but we would really love to hear from you, because we have a lot of questions to answer at the end. We'll go through those. So when we talk about what the people should have to do as an OHCDS, we incorporated some of the ideas we thought made sense for an OHCDS to assist in getting homes interested and supported to go through the steps of providing these much needed services to Alaskans. Can you think of more? This is just a sampling, but there are there glaring things we're missing here? Please feel free to type into the chat if you want to suggest any items. I can't see the chat, but we'll go through it at the end. And then, we also had sort of the dream of being able to pay an initial support fee. So we understand that, like, people come in and they say, I want to be an assisted living home, or I want to provide family home habilitation, and they don't really have a concept of what that means. And so the OHCDS, like SDS, would have to walk through people, help you understand the requirements of being a family home. How do you fill out an application? What are the licensing requirements? What are the background check requirements? Those are the kinds of things that are the technical assistance we see happening on the front end. And we would want to make sure that the OHCDS is compensated for that, because I think that's a very important piece of making sure that we have homes wanting to go back into this field, and we want them to go into it for the right reasons, and we want them to go into it and stay a business partner, and not jump ship because that disrupts the people we serve. Again, if you can think of more, would love to hear it. We will send these slides out after this presentation, so you'll have time to go through these and give us comment back or make other suggestions. And these aren't all the suggestions that our team came up with. They're just some of the real basic things. And I threw them in here from a spreadsheet, but again, it's not all inclusive, but we would love to hear from you. These are the possible responsibilities of an OHCDS for ongoing support. So we recognize there's that initial setup, but then there's also perhaps, well, there are also lots of things that happen for ongoing support. You know, the bottom one here, conduct on-site evaluation at least once a month, including one unannounced site visit during any 6-month period. Is that too much? Is that not enough? We'd love to hear it. You know, the OHCDS would have to monitor to ensure that the home, so we need evidence that the home is compliant. We need evidence of that, or we need evidence that you're actively engaging as an OHCDS with these homes to give them oversight. And so we'd love to hear what your thoughts are on this. And I think we had a poll, did we not, that we were going to put out into the world?
Hey, Lynn, this is Jordan. Yes, we have a couple of questions we'd like to actually poll you on using some of Zoom's cool features. And then we just also have a question slide that we'd like to kind of go through. You were not limited to those questions, but just to kind of get your thoughts going and get a little bit of feedback. So if we want to launch that poll with the first question, let me see. Okay, everyone should see the first question come up on their screen. If you want to go ahead and use your screen to answer the question. The first question is, how should the administrative fee be structured? So we give you a couple choices, and then if you have a amazing, wonderful idea that we haven't included here because we haven't thought about it yet, please email us at hss.dsds.policy@alaska.gov because we'd love to hear your ideas. And certainly we are not limited to only these two choices. There could be something else great that we just haven't thought of yet.
Mm-hmm.
I'll give people just another moment to finish up. I see we're getting some good participation. It looks like there's a strong, let me just, not to sway anyone's vote, but there's a strong preference for an initial onboarding fee and then a monthly fee. At the moment, we still have a couple more votes trickling in. All right, great.
Very awesome.
Let me see if we can do the second poll. Okay, I'm going to go ahead and end that one. And our second poll question launch is how helpful do you feel an OHCDS would be for you? So the choices are extremely helpful, somewhat helpful, neutral, somewhat not helpful, or not helpful at all. I know not everyone here is a provider, so it may not apply to you if that's the case, and we understand. But
Maybe we could say, how helpful do you believe an OHCDS would be?
Yeah.
And then everybody can answer.
Looks like we are getting some responses in, and they're kind of all over the place, which is good. We like to see areas where there are still questions, or where, you know, it looks like some folks are unsure about how helpful exactly it would be. Mm-hmm. Which makes sense. Once you get past the OHCDS as an acronym, then you get into what it actually does, and it is a bit of a learning curve even for us. So we completely understand. And I will end that poll here. It looks like we are at about 16% think extremely helpful, 31% somewhat helpful, 44% neutral, 3% somewhat not helpful, and 6% not helpful at all. So that is really helpful for us information. So thank you for participating in that.
Mhm.
And then Lynn, if you want to go to your next slide,
Yeah.
which has kind of a list of questions to consider.
Mhm. And these are fairly big questions. They're not easy to answer, which is why we haven't tried, even attempted to answer them yet. So, you know, would love to hear from folks again. You know, how should an OHCDS demonstrate financial readiness? You know, we've gone round and round. You know, we sometimes require people to show that they have money in the bank, but that doesn't really say how they pay their bills. It doesn't show if they've had maybe sanctions for not, you know, following through with something. Maybe their homes haven't had enough money to operate. Those would be pretty big red flags for us, to say you probably shouldn't then handle other people's business. But we'd love to hear from you on that. And then the other thing is, you know, when an individual rendering home gets connected to an OHCDS, we would hope that it would be a great relationship and people would stick there for a very long time and go about their business delivering the service. But as we see sometimes with other things, providers move around. Should that be limited? Should we require them to stick with the OHCDS that they chose for a certain amount of time? Do we even need to think about that and care about that? Those are just some of the things that we've been stewing about or thinking about. And then if they do want to transfer from one OHCDS to another, how do we handle that? If it's in the middle of the month, if it's, I mean, how do we care for that? Or do we need to? And then should the rendering provider have a billing time frame more explicit than the annual timely filing? So, you know, we know that you have up to a year to bill currently, but like, what if the individual renderer is waiting for payment and the OHCDS has not submitted the claim? What's the timeline that we should, or should we establish that? Who decides it? And so, and then again, for the payment structure, we sort of asked the poll about that. So, and, or if there's suggestions for a different model, again, I'd love to hear from you. And then, you know, the big question of insurance is, we have been going sort of done our own research and trying to decide if a rendering provider would need to have their own independent insurance, if they could be covered under their home insurance, or could they really be covered by the OHCDS insurance? And if people have experience with that, I know a lot of people really have struggled with insurance in the past, and then others have said, nope, it was easy peasy. So I think that's really what we need to hear from you about. So we can structure it in a way that's beneficial to everybody involved and keeps people safe and make sure we're covered.
And just to kind of give us a framework for time, we have about 11 minutes, and then we just have a quick wrap up comment or two from Director Newman. So I do see a couple of questions coming in the chat. You don't feel like you have to answer all of them. Maybe some speak to you more than others. If you want to put your question in the chat, we're going to start picking some of them out. If you'd like to speak your question and you would like us to unmute your mic, please, like we did before, go to the bottom of your screen, go to reactions, and actually raise your hand, and we will work on getting there. So the first question, Lynn, that we have in the chat is, with the added administrative structure for an OHCDS, is that the cost deducted from the reimbursement rate that the rendering provider would be paid by the state of Alaska? And has there been any discussion on setup and monthly fees for being an OHCDS? And then just following that, will there be a set administrative fee for all OHCDS?
All very good questions that we don't have the answers to. I will say that it won't be taking the money from the rate that's already there. If we can advocate for, what we would like to advocate for is that it would be a very separate amount that would be billed as an administrative fee. And we wouldn't take our current rate of whatever it is for family home and then carve out 3% or 5% or whatever the administrative fee would be, and then make a separate rate for that and reduce that. I'm not in control of the budget or how we would set this up, but I think our ask is that we would add an administrative fee to care for that. But Tony, I don't know if you wanted to add anything to that.
Just thank you, Lynn. The only thing I would add is that, yeah, we would need to work with our partners at the Office of Rate Review, right? The entity responsible for setting the Medicaid rates generally. This would be another form of rate that we would lean into them for their expertise and assistance in establishing what that rate will be.
Right. And we have not started that work. I will go back to that because we haven't started that work because when we go back a few slides to this, these are all things that affect what the potential outcome of the rate would be. And so we really need to define these and figure out what it is, what's the time equivalent, and what do we think we really want to pay for or want people to provide? What's the basic and what is, what's the nice to haves? And then we give that over to our Office of Rate Review and they go through it methodically and try to figure out what that rate would be. I also think, nobody's wanting to decrease amounts of money to anybody. And so that's really, what I'm saying is that we would advocate for this separate administrative fee. And then did we answer all those questions, Jordan?
Well, we actually have another question or a comment in the chat that I think is really helpful, which is about the insurance question of the last question on the slide.
Oh, yeah.
So our commenter says they have already asked the question about insurance to the insurer, and the insurer said that as an agency, they cannot provide liability or property insurance for a property that they don't own or lease, as they don't have control over that location or business that the insurance would require. And since they aren't the owner of the property. And so they're commenting saying they think likely it would be challenging that the rendering provider will need insurance and will not be able to be covered by OHCDS insurance.
That makes sense.
Thank you. Thank you for that comment. Really, really appreciate that.
Mm-hmm.
Do we have anyone who would like to have their mic unmuted to ask a question? I'm not seeing any hands up, which is totally fine. Oh, I see Kim. Let me see if I can have the power here to unmute you.
I think I can unmute myself. Can you hear me?
Oh, great. Excellent.
Yeah, you don't even have to unmute me.
We can hear you.
I was going to type this question in, but it's easier just to ask it. And I'm imagining, like, especially adult host homes, that would be a service that would be really great in more remote areas. I'm imagining that there might be a central organization like a tribal health organization, or perhaps a statewide nonprofit that would be the OHCFD entity. So when I think about monthly on-site visit, that seems, I wonder about that. And especially because you also have a care coordinator whose job is to ensure people are safe. And I guess my thinking was just feedback wise to think about how do you make this doable, especially if maybe you have some hubs that are going to do it around in different communities, and what the QA with the care coordinator as well. I mean, I think there at least, once a year needs to be a definite like on-site something. But that was just one of my thoughts, is how to make it work in Alaska, where you can't just get in your car and go do an on-site visit, as you guys very much know.
Yeah, Kim, I appreciate that. I think I'll just tell you one of our sort of thoughts on that is that oftentimes when something new comes up, we go, oh, the care coordinator could do that. But it is also putting more burden on the care coordinator to be responsible. And we've heard from care coordinators, they don't want that responsibility. They didn't want it in settings. They don't really want it probably for this, like to be like, how would we know? Would they be the one that would go in the home and they'd fill out a form on the home? How do we ensure that there's, they're checking for safety things? It can't just be a generic self-read, you look good. Those are the kinds of things we're concerned about, I guess. So
I think that's good. The care coordinators on the line probably love that. In my mind, I'm just thinking that what is the purpose of the monthly visit is to make sure someone isn't in being neglected or in danger. And hopefully the care coordinator, that's part of their core duties, right? Because a monthly on-site visit, if you're in a hub, in a rural, you're in Nome and you have to go to whatever those villages are, they can't get there monthly. So.
Mm-hmm. We have also talked about like, could, you know, when we go out places, we don't go very often, but like, you know, leveraging licensing that goes out every so often. And then we go out, you know, every so often, but we often have some gaps in how we, you know, when we go. And so we can't take on the responsibility necessarily, but that does play into the part of how much you pay in OHCDS and what we expect of them. So I appreciate that comment and that feedback. Mhm.
Thank you, Kim. Looks like we have another hand up. Michelle, are you able to unmute your microphone?
Yeah, just wanted to clarify kind of off of Kim's with the, I'd asked the question in the chat, who assumed audit liability? And Kara had indicated that it was the rendering agent. But if there's supervisory quality assurance expectations being laid, that just makes me question, you know, whether if someone's falsifying notes or they're not providing the service that they're saying, and you opt to bill for that, just wanted to have that clarified along the way, that if you take on this service or this expectation, that you are, you know, you're not quality assurance
Protected.
services are being provided for audits.
And I think I appreciate that, Michelle. I was just going to say that in some of the rules that I was reading, and Mary could probably look at this, I think I felt like in this relationship, both entities have some level of responsibility, but that's why we are trying to clearly lay out what is the individual renderer's responsibility and what is the OHCDS responsibility, because you are maintaining your certification, and that's what we heard, right? You don't want your whole certification for all of your ResHab to go bye-bye because one provider neglected someone, and you did all your due diligence. You went in, you trained them, you provided the notes, you gave them the operation manual. You know, you did everything you were supposed to do. You did your visit and everything looked good. We can't really hold you accountable for that. That would be where we would hold them accountable. And when they're individually enrolled, that's what gives us the leverage to be able to say we can separate those two. When they're not individually enrolled and they're your subcontractor, like that's set up now, it makes it a little grayer. We're trying to clearly delineate those.
Yeah, Lynn, that's what I was just going to say. I think in our research on this in other states, we saw that, you know, when an OHCDS conducts any sort of mistakes or has any kind of errors that result in the service being delivered that's not authorized or provided to somebody who's not eligible, there needs to be some level of financial liability for that. So it's a great question, Michelle.
And we really want to be careful that we're calling you the Administrative Services Organization as the OHCDS. So it sort of, it doesn't put you responsible for the actual service itself necessarily, though you're overseeing and, you know, you're our sort of oversight agency, if that makes sense.
Yeah, I think it's just it's a potential gray area that, you know, even now with care coordination and a service provider, or a guardian, if those duties aren't being performed, a service provider will jump in sometimes, and just the lines get really blurred. Whose responsibility is this? So as we move in this direction to have those lines be very clear will be very helpful.
Mm-hmm.
Tony, I see your hand is up, and conveniently we are also at time. So
right.
if you
Right. And I just wanted to do two things real quickly. Thanks for posing those questions at the end of your presentation, Lynn. I know we've found what's really helpful is when the groups that are represented here, like AADD or the Governor's Council, when you guys get together and take the kind of questions that Lynn posed at the end of her presentation and provide us with a written, you guys sit together, put your minds together. It's really helpful to have that in writing. So I just want to encourage that. And the second thing I wanted to do is if she's able to turn her camera on, just say hello, get a hello from Mary, and any reactions or comments from her on the presentation.
Thank you, Tony, and thank you, Lynn, and the whole team for all of the work that's been underway. I'm hopeful that with all the investment of time that Alaska has put into the OHCDS structure, that it really does further your opportunity to grow the service and increase opportunities for individuals who otherwise wouldn't be rendering services within the state. And just, wanted to give a hearty congratulations to the state for being so thoughtful on all those different aspects. Many states are using OHCDS very successfully right now. And so there's a lot of learning that can occur from that cross-state collaboration. Yet I think because Alaska has so many unique aspects, it becomes so important to be especially tailored to the needs of Alaskans. And I think your team has done such a beautiful job of really thinking that, and the questions today from your partners have been, I think, remarkable and will help illuminate areas of further work to be done. So just thank you for having me, and it's a real privilege to be able to work with you on this.
Thank you,
so
Mary.
much, Mary.
Thank you, Mary.
Jordan, back to you.
Well, we are at time today. Thank you everyone for all of your participation. This recording will be on the policy YouTube for people to watch later or refer back to. And if you would like a copy of the slides, please send me an email at hss.dsds policy@alaska.gov. Sorry, sometimes I forget what our own email is. Thank you again for joining us. I know we've had a lot of webinars lately. Pitch for next week. We do have one next Wednesday on acuity. So we'd love to see you there. And thank you, Lynn.
Thanks, everyone. Take care.